Lucy Snider. I'm really thankful that you're on with me today. This is a conversation I've been looking forward to have. I have this list of ideas for podcast discussions. And I did one episode 69 with another physiotherapist talking about the pelvic floor and trauma and how the nervous system is related. And it was one of the most downloaded episodes. And so I thought we need to dive into this a little bit deeper. And I know you yourself see a lot of different patients that have had experienced sexual trauma in the past. And this is something that shows up a lot in our appointments as physiotherapists. And I think quite often people don't expect it to come up.
Mhm.
And so, how just to kind of set the stage a little bit, when someone decides to book an appointment with a pelvic floor physio, maybe someone has suggested it, or maybe they kind of have a hunch that something's going on, and sometimes that can be leaking or um, pain, or it can, just general pain that lasts all the time, or pain with intercourse. Sometimes it's that they've heard of the pelvic floor as it relates to birth, and they're feeling really nervous about birth, and so they want to come and be proactive. I've seen a lot of people in the menopausal age who are just, things are really starting to show up now, and so I'm going to address this. One of the first things when people book with us, we'll send them in an intake form. On my intake form, I ask, why are you coming in and all that. And there is a section where I ask, have you ever had any unwanted touch? Was your first sexual encounter positive or negative? I don't go into a lot of details, but
Mhm.
my reason for asking that initially is I just want them thinking what things might come up in our session. Some people answer it, some people don't. And it's a very individual thing, as far as whether I bring it up or they share it with me. But the reason it's relevant is because as soon as someone comes in with symptoms, our job as a physio is to be a bit of a detective and figure out what's the issue in the first place? Why is this showing up? Because the pelvic floor is a very reactive muscle.
Mhm.
And very much tied to the nervous system. And so our job is to figure out what's going on in this person's life. What are some of their habits? What are some of the things they do repetitively? What are some of their beliefs about this group of muscles? And that's when quite often, a history of something, any history of something, I say sometimes in the negative bucket, can create, tension, upregulation of the nervous system. And so I always want to normalize that for people, in that this is normal that you're getting some of these symptoms. However, I am not a psychotherapist. And there are a lot of times where in the appointment, maybe they bring up that they are concurrently working with a therapist. And the therapist suggested they come, or they're starting to connect the dots that, oh my gosh, my physical and emotional or mental considerations are intertwined. They start to kind of connect those dots. And sometimes I'm the one that's bringing up, have you ever worked with someone to process some of this? And so that's my long-winded introduction, Lucy, as to why I wanted you to come on, because I'd really like you to help me shed light on this topic and share kind of some of the ways that you would approach this for people and helping them process previous traumas. And I think the first time I met you, Lucy, is we might have done a talk at the same time. I'm actually a little bit unclear on that. Like we might have
Yeah, we did
presented to
that
a group.
RBC Women's Health event
Yeah.
for that
a-
at Pyramid Hill Winery.
Yes. And so I think that's the first time we met, and we've
Yeah.
connected a few times since.
Mhm.
And I know your clients really love you. And quite often when I'm talking in the community about, oh, I have a there or someone I'd love to refer to a therapist about, some sexual traumas, your name comes up all the time.
Mhm.
So with all that said, would you really quickly spend some time, quickly and thoroughly, spend some time just introducing yourself to the listeners?
Absolutely. And first of all, thank you for having me. Yeah, so my name is Lucy Snider. I am a sex and relationship psychotherapist. In BC, we use the term registered clinical counselor, or RCC is kind of my professional designation. But a lot of my, you may have picked up on that I'm not from Canada. I'm originally from the UK. So a lot of my training and background comes from when I was working in the UK. I worked in sexual health. So kind of like the equivalent of interior health. I worked for the NHS in London, excuse me, in one of the largest sexual health services in London. And I had two roles within that service. One was as like a health counselor. So I was the person that was kind of giving people their diagnosis of infections and kind of providing emotional support around that information, all infections. So, obviously chlamydia, gonorrhea, but also things like HIV, hepatitis C. So supporting people in the emotional aftermath of a diagnosis. And also anything really that walked in through our doors. So because we were a central London clinic with a walk-in facility, really we saw a wide range of presenting issues, including things like sexual violence, sexual assault, unfortunately, things like intimate partner violence, sex trafficking, sex workers. So lots of different presentations of people coming in. So that I was very much kind of the emotional support and the counseling aspect of people's sexual health. And then within the sexual health clinic, we also had a sex therapy clinic, and I was a sex therapist within that clinic. So that was working specifically with people coming in with sexual functioning problems that were not medical, so they were psychological. So things like problems getting or maintaining an erection, and for women, difficulty with maybe things like penetration or orgasm or pain with intercourse, those types of issues, but that are rooted psychologically. So a lot of my work comes back to trauma, because trauma really underpins so many of these issues. And so it was something that was always at the kind of forefront of the work that I was doing. And then after moving to Canada, which was about 5 years ago now, I have my own private practice, so obviously seeing clients privately there. And then I also work for the Central Okanagan Elizabeth Fry Society, where we support survivors of intimate partner and sexual violence. So I'm the counseling supervisor over there. And again, yeah, really specifically providing counseling support for people that have gone through either sexual or intimate partner violence or both. So yeah, that's me.
Will you speak a little bit to, like statistics and kind of numbers of people? Like I know I've heard before, like 1 in 3 women will be have experienced sexual violence or sexual assault at some point in their life. I don't know if that's accurate, so please correct me if I'm wrong. Are we seeing changes in trends, or like trends in numbers or trends in accessing help? Like, can you speak to that a bit?
Absolutely, yeah. Yeah, 1 in 3 is still the number that we have as a statistic. What we have to be mindful about that number is obviously that's people that disclose
Mhm.
their assault. And we do know that a large number of people typically don't disclose. So it's likely that that number is higher. It's just that that's the data we have based on disclosure. In terms of like, I feel like I don't want to be negative, but I don't know how much change we're seeing. Like, it's still such a challenge for people to come forward. There is still such a stigma around kind of, victim blaming is still huge. That with sexual violence, it seems to be one of the only crimes, in my opinion, where people question you. I think if you were ever to tell somebody like, "Oh, I got mugged last night," people's reaction would be like, "Oh my God, that's awful. Like, I can't believe that happened to you."
Mhm.
But you say like, "I was raped last night," and people's immediate kind of is
Mhm.
like, "Well, were you really?" Or, "Well, what were you
Mhm.
doing?"
Mhm.
There's still this kind of like, victim blaming, or this like not believing of people that comes first, and it's just very stigmatizing, very shaming, and it's very hard for people to feel safe enough to come forward with disclosures when they know that that's probably what they're going to face. And we do work at Elizabeth Fry Society. We work closely with the RCMP, and there is the dedicated team down there that supports survivors, and they are great, and they are doing great work. But I think there is still a perception that, the RCMP is not necessarily going to be believing, or that we're going to have to disclose maybe to like a male officer. And so there is just a lot of barriers to people even disclosing. And then when we get into disclosure, that it's very difficult often for these cases to even make it to court, because if we don't have enough evidence, which is common because a lot of time these things happen and we don't have evidence, and therefore the Crown really just can't do anything with that information. It's not that they don't want to, but with a lack of evidence, it's just really hard to prosecute. So then it kind of also goes back to like, is there any point in reporting or disclosing, because what's really going to happen? So I do think there's still a lot of barriers for people coming forward, which is challenging, but we're working hard at our agency and other agencies to try to improve access to at least support services, and let people know that like there are services available where we will believe you and we will listen to you and we will get you the support that you need. But sometimes support doesn't always look like justice, which is unfortunate. But it's maybe just recognizing like that's the reality of our culture, unfortunately.
As a physiotherapist, I think, when people come to see us, I mentioned that they're not usually they wouldn't come in and say, I'm here because I've had sexual trauma. Like that wouldn't be a reason that they would access our care. And I think, one of the reasons we get trained, especially as pelvic health physios in trauma-informed practice, is because inevitably, it very commonly comes up because they have time with us. We're compassionate people. They're already sharing a lot of intimate details that they often don't share with anyone else, and they feel comfortable sharing with us. And obviously, there's so much only in our scope of practice. So which is why I feel really grateful to know people like yourself in our community. I'm curious to know, people will come to see you for all sorts of reasons. And I get that this is not a black and white answer, but I'm kind of curious to know if people come in, kind of say, I'm here, Lucy, because I've had sexual trauma, or I'm here because I'm having relationship issues and it comes up. Do you know what I mean? Like,
Yeah.
do people usually access you kind of understanding that their issues stem from that? Or do you feel like you have to tease that out for them a little bit more?
Honestly, I feel like it's 50-50.
Yeah.
There's definitely people that come in who, like you said, on the intake form, it's right in there, I'm a survivor. They may even have had previous therapy around that trauma, but now it's like they're really coming specifically for like the sexual function or the sexuality piece. And then I think there's the whole spectrum from those people right through to people who have no idea, and it's only when they start unpacking some of their history that maybe even I have to say what you're describing sounds non-consensual. And then obviously that's very difficult for them, because in that moment they're really starting to realize like, oh, like this is an issue. And then in between we might have people who have some awareness but they've never really unpacked it, and or people who I think a sort of point that's important to make is, while yes, of course, with any kind of trauma, we would anticipate that there might be certain responses and symptoms that we would identify as being, trauma response. However, it's not to say that like just because you've experienced sexual trauma that you will definitely have sexual difficulties. I think that's just important to note that, like, as we've just already said, very, very common, unfortunately, to experience sexual violence or sexual trauma. And yes, there are people that will go on to have sexual difficulties, but there are other people that won't. And there's no right or wrong response, or there's no right or wrong way to feel after sexual trauma. So just to say that there's other people that might come in who say, yes, I have had this experience. However, it's not something that really I feel is impacting me. I'm coming for this other issue. So I do think there's a broad spectrum of presentation, sorry, with sexual violence and sexual trauma, and none are better or worse than the other, and they all are valid and normal. Yeah.
I'm curious to know, because that I kind of have laid out what would make me think of someone like you is, if maybe someone disclosing something with me, and we talk about it, and I always share, of course you have some of these symptoms and these would be potentially some of the reasons why. But have you processed this with anybody before? Do you talk with anyone about this? Do you work with any therapists that have helped you, um, move through some of this? How does that, how do you make the link with us? So what would be some reasons why in your sessions with your clients, you'd maybe thinking of someone, they need to see someone that comes at this from a physical point of view?
Mhm. Yeah. So I guess in terms of like the most common presenting problems that I would see for women or people with vaginas coming in,
And men
um,
too, Lucy. Like we see lots of men as well, but
sure,
yes.
absolutely. Yeah. So I guess typically it's going to be, um, difficulty with penetration. So whether we would consider like they can't have any penetration at all. So often people might describe that as like almost feeling like there's like a block or a barrier, like when they're trying to insert anything, like maybe they can't use tampons, they can't even put a finger in. Penis is definitely not going to go in, and it just kind of feels like there's a wall or a block there. For some people, they can achieve penetration, but they feel like it's not comfortable or it's difficult. Maybe the finger or the penis or the toy, it can't really go all the way in. There's just like a struggle with that penetration doesn't feel easy. So in terms of like the DSM, we would maybe think about a diagnosis, and they changed it recently. It's now called genitopelvic pain and penetration disorder, which is very easy to say and remember, GPPPD. But we used to call it vaginismus, so that basically like involuntary contraction of the pelvic floor that's not allowing for any kind of penetration. So in a presentation like that, I'm going to be working with as we've just talked about, maybe going through the history, what has like led up to this. Has it always been present, or is it following something else that happened? There may be elements of sexual education, and then with sex therapy, we are working through getting more comfortable with our body, learning our sexuality. And I will work with, either dilator therapy, which is learning how to get relaxed and start to gradually insert dilators, which are just like little plastic tubes that go into the vagina in increasing sizes. But I think once I get to that stage, um, I don't have like the in-depth physiological knowledge that you do about the pelvic floor and how to really like, I know that you help women to really even understand like how to connect to their pelvic floor and know what it feels like when it's tense, know what it feels like when it's relaxed, and then exercises to work on relaxing it and just get like that mind body connection that is so important with any of these issues. I feel like the pelvic floor physio like just comes in and gives like a much like deeper level of knowledge around that piece that I don't have, that I find is very helpful for those kind of presenting problems. Even with other things like, people that maybe experience difficulty with orgasm, we know that that can also be linked to overly tight muscles or like struggling to release, because orgasm is release of energy in the body. With male presenting problems, similarly, we can have, if there's a difficulty getting or maintaining an erection, or even difficulties with ejaculation, a lot of it can be that there's just this mind-body disconnect, right? That, starting with like, what does it feel like in your body when you're getting aroused? And a lot of people will say, I don't know, I have no idea. So I can obviously help them with, again, sort of educational piece, but I think you provide that very like, in-depth, hands-on physical piece of getting them connected with their physical body, and understanding really what the muscles are doing and what they feel like in that real physical way.
And I think like just so listeners know, like, yes, bang on what you said. And I think like just so listeners know, I think there's sometimes a bit of a nervousness or a barrier to them coming, because I think a lot of times we're associated with internal exams, and it's absolutely in our expertise to do that. But I would never make someone do that. And so some therapists do, I don't want to say insist on it, but they have more comfort with doing it. But is absolutely in your control to pick a therapist that
Mm-hmm.
doesn't do that. And I always offer it to people. Do you feel like it would be helpful if I do an assessment, with my finger inside your pelvic floor or in around your pelvic floor? Do you learn that way with palpation? Is that how you learn, or would you rather me show you images or what have you? But we will meet you where you're at. And I
Yes.
like to explain it at the beginning. Like, I think education goes a long way. These are not muscles or body parts that we're used to learning much about. So
Mhm.
sometimes just showing models or visuals or explaining people like that, people will say, "Oh my gosh, that makes sense. I'm actually, there's nothing wrong with me. This is normal." We're not meant to think about these muscles too much, but some different things, our habits, our beliefs, our previous story can kind of change how the muscles react. So, yeah, we'll often get them to practice or recognize, what does it feel like to hold these muscles tight versus relax? And then I usually give them the homework to notice things in your day. I just want you to notice some of your habits. And that's where a lot of people will say, "Do you know what I think? I walk around with a lot of tension." And I always say, I write down, you're not going to leave here knowing, but I just want you to think why. Like, why do
Mhm.
you think? And that's where often they'll say, my mom has always told me to tuck in my tummy, and I can feel that my pelvic floor tightens when I do that. Or I always have heard as a woman, I'm supposed to have a tight vagina. So I think I hold down there all the time.
Classic
And
tight vagina narrative.
exactly, like the number of people that think that,
Mhm.
and so I think just establishing an awareness, and I always say like it's establishing control, because I think a lot of times people don't realize that they have more control of those muscles because they're just so regulated by the brain. We're not used to having to control them. But
Yes.
sometimes when you back it up and realize how much control you have through your breathing, through your mindfulness, through different areas of your body, sometimes I think that's the first thing to establish. And then, like you said, maybe we would move to a dilator. But I have had a lot of clients that have been traumatized by objects. So a dilator is not the next step for them, or maybe ever a step. Maybe
Mhm.
they feel more comfortable with their own finger palpating, or maybe mine because they see it as
Yep.
comforting or something like that.
Absolutely.
So
Or partner, getting more
yes,
involved.
exactly. And so I think a lot of times people associate physios with, oh my gosh, they're going to put their finger in and try to stretch my vagina. That's what a lot of
Mhm.
people think, but it's
Sure.
not about that at all. Yeah.
No. Yeah, absolutely. It's interesting, like, and again, this is where I feel like our work really mirrors each other in such a complementary way because, I really also start with the awareness building, education about mindfulness. I know mindfulness is such like buzzword at the moment.
Hmm.
But and people kind of go, oh, I don't want to meditate, right? And I always say, like, okay, like, yes, meditation is a form of mindfulness, but mindfulness is not meditation, right? Like
Hmm.
the mindfulness is about just being present. We spend so much of our time um multitasking, right? Our focus is split. We're thinking about like what we need to do later, and our phone is buzzing, and our kids are talking to us, and we're always able to kind of like split our focus in lots of different ways. Usually it's helpful, right? We get a lot done. We're able to multitask. But it means that that muscle of being like present in the moment is for most people is very weak, right? That we really struggle to just be present, just bring that awareness internally in the moment. And it's so helpful for so many different things. Simple but not easy, but helpful for, like you're saying, first of all, just building that awareness, noticing. Also helpful though for regulating the nervous system, bringing that heart rate down, being able to get into more of the relaxed or rest and digest state. So definitely it's like, yeah, we're going to start here. And, for some people, even like that's all the work is, right? Like you're saying, yes, we always move with the pace of the client. If we do move to inserting things into the vagina, yeah, there's so many different options, even starting with something like a Q-tip.
Hmm.
The dilators themselves, like they do start quite small, but it's still typically the smallest one usually is about the size of a finger, if not a little bit bigger. And for some people that's still too big, right? If nothing has ever been into the vagina either at all or maybe for a long time, okay, well, let's start with something a lot smaller. So yeah, always understanding that good therapy, either I think good psychotherapy or good physiotherapy, is led by the client, right? It's not led by us.
And I think it's important because I know we would both approach this the same way. A lot of those dilators are marketed towards like you need to put them into stretch, but I
Mm-hmm.
love how you describe that it's learning to accommodate or learning to allow. It's not about just putting something in there and stretching it.
No.
And I think that can be very scary for a lot of people
Mm-hmm.
because there's a reason you're holding tension, and that's where the kind of the mind comes in and the understanding comes in, is like, what does the brain need to allow, right? It's
Mhm.
not simply just putting something big in there.
No, absolutely not. Well, as you know, like we don't need to stretch the vagina.
Yes.
The vagina can stretch up to, correct me if
Hmm.
I'm wrong, pretty sure 300% of its original size, that we are designed to birth a child. So it's again going back to what you were saying about that there's nothing wrong with you. This
Hmm.
is about understanding how the brain and the body are communicating,
Hmm.
which is about your body is tensing because it's trying to protect itself, and therefore it's difficult for penetration to happen. But that's not about having to stretch your body. It's about allowing to train or help your body to recognize, I am safe, I am not in danger, and I can start to accommodate things coming inside my body if I want to, right?
Another example of patients that I see a lot of are those that are quite nervous, like their past and, events or re- upbringing or what have you makes them quite nervous for birth. Whether it be there's going to be people spreading my legs, there's going to be people looking. Um, I don't think I can let go enough. Like they recognize that they have a pattern of holding for different reasons. Maybe they have pain with intercourse. And so now that all of a sudden they can picture that pelvic floor stretching more than it ever has, they have a lot of nervousness. Is that a group of people that you see a lot of?
Yeah, I would say it's not a huge group, but it definitely comes up. Typically people that are already experiencing difficulty with penetration, if they do happen to become pregnant, it's common and normal that that would then translate into pregnancy. For a lot of women, it's also like the vaginal exams that go along
Mhm.
with being pregnant, speculum examinations or bimanual, the finger examinations. All of it can just create a lot of anxiety. And I think as well, as you were saying, coming back to the control, like you said, that
Mhm.
unfortunately in a lot of these settings, it's very medical led, and it's very much like this is what needs to happen and it's happening whether you kind of like it or not. We're not really going to explain to you why or what's going on. It's just going to happen, and it's a very unhelpful environment for someone who's already nervous about those types of exams to be put in. And unfortunately, we do see a lot of re-traumatization, from people that have gone through those experiences. Yeah.
I have a question on that note. So as a physio, those clients, I mean, same type of thing. I'd be helping them understand the pelvic floor, understand how they have control of tension and relaxation, using different visualizations, breath strategies, so that they can, oh my gosh, I can relax. I do have control. Helping them understand how to advocate for themselves and how to advocate for what they feel they need to be able to relax in the birth situation. However, some of the examples that have come up before are things like, oh my gosh, all of a sudden in pregnancy, I'm realizing my previous sexual trauma is contributing to this. Like, I didn't dawn on me before that something like this would happen. Or I had a patient one time that shared with me, she said, I am really struggling with the idea that I'm having a boy. I
Mm.
realize I don't love men. I hate men, or something like along those lines.
Yes.
But I've heard before that, and oh, this is what I'm looking for from you is clarification. I've heard before that it's not the best time for people to process some of that stuff in pregnancy.
Yeah, it's definitely like, again, nothing is ever black and white.
Yes.
The reason we say that is, probably fairly understandably, you're carrying a baby, baby is exposed to everything that your body is exposed to. Processing trauma and doing therapy is stressful. It's stressful on the body and on the nervous system. And we don't, like in any situation, of course, we would never encourage somebody to place undue stress on their body, because that little baby inside is going to be exposed to all of that elevated, cortisol and adrenaline and all that kind of stuff. So again, it's kind of almost like a cost benefit analysis. It's, how much is this trauma impacting you at the moment? You're only pregnant for 9 months, right? So like, is it impacting you so much that you can't function and we really need to deal with it? Okay, then I would say that the sort of benefit outweighs the cost in that situation. However, if you're kind of saying like, well, no, I'm aware it's there, but I'm okay, then I would say, all right, well, let's just maybe focus on, being pregnant, taking care of yourself, staying as calm and rested and all that good stuff as much as possible. Once baby comes, then you can unpack this at a later date, right? There's no, we can, we're very good at it, right? We can table stuff, right? We don't
Mhm.
need, just because we've had an awareness of something and it feels like, oh, this needs attended to, it's, you've probably lived whatever, 30, 35, maybe even 40 years with this, and you're fine. So we don't necessarily need to dive into something just because there's that awareness of it in the here and now. We can definitely park things, table things, come back to it when we have the capacity and space and time to focus on it, right?
I have had several clients who are working with therapists at the same time that use EMDR as a
Mm-hmm.
tool. Can you explain for people what is EMDR? Because I think it's a very trendy term or what have you, the
Yeah.
tool right now, good or bad. I mean, I'm not trying to say, but I'm just curious if you'll explain because I have a lot of clients that are processing traumas using EMDR therapy.
Definitely. So EMDR, stands for eye movement desensitization and reprocessing. So eye movement, it means it is a type of therapy that employs movement of the eyes, typically that they are moving across the midline of your body. So that's essentially that you're just moving your eyes from left to right, and that your gaze is crossing the midline of your body. The reason that we use the eye movements in that way is, the theory goes, that we are stimulating both sides of the brain when that's happening. So it's a stimulation of the right side, then the left side, then the right side, then the left side. The desensitization is about that when we sort of, traumatic memories are held differently in the body, right? In a way that they often kind of get stored along with physical sensations, maybe negative beliefs about self, unhelpful thoughts, horrible images, maybe even sounds, smells, sensory, lots of stuff, and it all kind of gets stored together. And so in that way, those memories can be very visceral and very upsetting, right? Like that's why it's trauma. It's an upsetting memory. If you kind of compare that to maybe even trying to think about like, what did you have for dinner last Wednesday? You can probably maybe remember, but it's like a kind of foggy, like, no, I'm not too sure, right? Versus a traumatic memory will almost be like kind of
Mm.
like a film, like a movie is like right in front of your face, like, and you can see it and hear it and feel it, right? So the desensitization portion is about reducing that level of kind of emotional impact that goes along with those traumatic memories. And then the reprocessing is about trying to process that memory in the same way that regular memories are processed, so that again it becomes that it's not that we forget, but that if we were to recall that memory, it doesn't have the same emotional charge as it does in the here and now. So that's what that stands for. Like a lot of psychological theories, we don't really know why it works, but there is a lot of evidence to support that it does work, right? So I think with all of these things, I would always say to people, like, give it a go. But if it's not for you, then that's fine. It's just another way of accessing psychological information. There's lots of different ways to do therapy, and EMDR is just another way of doing it. Some people really like it because it's quite an internal process. So when you're in session doing an EMDR session, I'm helping you to connect to various different parts of memory. And then I'm helping you to move your eyes and kind of talking you through the process. But that's all the conversation we really have. You're very much just connected to what's going on for you. I'm checking in and you're giving me a little bit of feedback. But that's all that's really happening on a verbal level. And so some clients really like that because they feel like they don't have to go into like a big story about, what has happened to them. On the flip side, other people don't like that because some people really feel like they want to talk about what happened to them, in which case then maybe EMDR is not for them. But again, it does have a lot of current research and results to kind of support that it's very effective for people processing trauma. Yeah.
It seems to be, this is just maybe the clients that I've seen, but it seems to
Mm.
be used a lot to process some childhood traumas.
Mhm.
This is just like, I know it's not the only thing, but I'm
Mm,
finding, and people swear by it. The number of clients that I've had that have been like, this has been a game changer for me.
mhm, mhm,
I can, I luckily have not experienced sexual trauma myself. Doesn't mean I haven't had other traumas. And I would
mhm,
say that I've had sometimes issues with, like, I can talk about things till I'm blue in the face, but I always
mhm.
say, like, there's something else down deep in there that I can't talk about.
Yes.
And I can see that, like, something like that
Mhm,
would be like, I just can't talk about it. I don't know how to describe it. I can't
mhm.
get past the film that you're describing about by just
Yes.
talking about something. So I can
Yeah.
see how it would be a different,
Mhm.
approach.
Absolutely. And so with childhood stuff, and there's a couple of pieces to that. Again, the theory goes that memories are stored in chains. And so memories are kind of linked. So again, traumatic memories can almost be, they are so traumatic because they are maybe linked to earlier experiences that for whatever reason are similar. So it almost creates like a combined memory. And so part of EMDR is actually processing all of the memories and maybe going back into childhood. Um, and the other piece of that is like in childhood, depending on what stage of development we're at, when whatever that thing was that happened, we may be pre-verbal. And if we're pre-verbal, then the memories are stored differently. That we don't actually have language. We may just have image or feeling or sensation. And so again, talk therapy will be challenging because you genuinely don't have like a verbal stored memory there. And so again, it's another way to access the information. Right?
It's very interesting. I have a friend who said that I could, share this without any identifying details, but she's someone who had like a trauma as a child, involved in a pretty high profile rape
Oh,
case. She was raped herself. I want to say around 10 years old,
oh my gosh.
and didn't seek out any therapy. Like, felt she was, managed quite fine. She can talk about it very freely. But
Mm-hmm.
one of the reasons she sought out pelvic health physio is, just kept saying, like, I have prolapse symptoms, pain. And as we started talking more and more, she's like, I'm noticing that, like, when that person moves, penitentiaries or whatever it's called, she has to be notified. And she
Yeah.
said those calls create more pain. I'm starting to
Mm-hmm.
think maybe because she can talk about it and talk
Yeah.
about it very openly. I think feels like she's handled it quite well. But
Mm-hmm.
starting to think, like, I wonder if this is tied to my pain because I'm getting a quote unquote flare
Yeah.
when it comes up. Yeah.
Yes. You know, the brain does a great job of protecting us. You know, we should
Yes.
always say, thank you, brain.
Yes.
Right. But the body remembers. Like, how many of those books are there? The body keeps a score, the body remembers, the body says no, right? So again, it's like, how is this information stored? And often it is stored physically. And the brain will do a good job of kind of either just, kind of hiding away the information or not storing the information in a cognitive way, right?
Mhm.
But the body will remember. So that's absolutely, again, a lot of the clients we see who may come in and say, oh, but I feel fine,
Mhm.
but I just can't have penetration, or I can't orgasm or it hurts or whatever. It's like, okay, what is your body telling you, right? And again, I
Mhm.
think that goes back to, there's nothing wrong with you. There's a reason why this is happening, right? Our
Mhm.
bodies are very intelligent and clever, and are always wired towards self-preservation. So whatever is happening is protective. And so we're not going to be like, A, we're not going to shame you or tell you there's something wrong with you. B, we're not going to charge in and like try, like you say, we're not going to just like ram a dilator in and try to stretch your vagina, because that's not the issue. The issue is trying to, slowly and respectfully and gently unpack what we think is happening until we get a sense of, you know, essentially communicating to the body, okay, you're safe, you're okay.
I love how you say that because I think that's one of the things a lot of people feel is almost like, why are they coping and I'm not? Why do I have this and I don't? And I think we quite often, when I say we, like anyone that's experiencing this will kind of feel like, what's wrong with me that I can't get over this? But I love how you say, I use this language too with people, is like, your brain is so good at protecting you. So thank you, brain. But
Yeah.
brain, the threat's gone. So we need that. And that's the nice thing. I actually heard one time one of my instructors in one of the courses I was taking it said that our nervous system is really good at putting tension in. It's not so good at taking it out. And I think that sometimes the that's where it comes with like just being almost like grateful or having some grace with yourself to be like, oh, my brain's just actually super like hovering a little bit. I
Mhm.
just need to help it diffuse,
Yeah.
because that usually will be kind of a top down um effect, right?
Absolutely, yeah. And that links to another piece of this work, which is often self-compassion, and that, of course we're gonna feel,
Mhm.
like you said, like feel broken, feel like there's something wrong with us. Maybe this is causing a lot of difficulty in your life, in your relationship, so it makes sense. But we just recognize where we actually end up creating more tension when we're saying to ourselves all of these negative kind of
Mhm.
critical things. And so another is like, okay, let's try to remove that piece, try to be compassionate. How does that shift things? How does it feel to be, come at this from a compassionate lens? Does that just help with like one piece of this puzzle, which is that, we don't need to be adding in more tension by being critical of ourselves?
What are your thoughts on, for listeners, you kind of mentioned a little bit about, you just kind of talked a little bit about the pros and cons of processing trauma and pregnancy, and that it's hard. There's a lot that goes into it. And if I was to share myself a little bit about some things that I've worked through, I could tell that I wasn't ready while my kids were young, if that makes sense, to
Mhm.
process some things. I
Yes.
could tell there was a time that I could dedicate to myself. I could afford to be sad for times in the day.
Mhm.
I could afford to kind of like think about myself a little bit more. And it felt like a good time for me to process some things. Um, but I guess what I'm wanting you to talk a little bit about is, if there's a lot of people that have like, I've put this off for a long time. It's not a good time. It's not a good time. It's not a good time. What when is a good time? And I know nobody has to do anything, but
No.
if someone said to you, when's the right time to dig into this?
Hmm.
One of the questions I had one time before I processed a lot of things, I was speaking with another friend who's a therapist, and, I said, "Am I gonna, like, cry all day after the sessions, or am I gonna, like, have a hard time sleeping because I don't feel like I can afford that?" And she really helped me understand, like, after each session, we tie things up or what have you. Can you explain a little bit to people that are wondering, when should I process some of this? Like, what would you say? What do
Yeah,
they need?
definitely. I think anyone considering therapy should definitely ask themselves these kind of questions. Practically speaking, you need the time to come to appointments. Um, Appointments can vary, but for most people, you're looking at bi-weekly is most common, so every 2 weeks. Once we get more into the work, we might space them out a little bit more. But that's common and average for most people. Um, Therapy duration can obviously vary greatly as well. There is a lot of evidence-based studies to support round about 8 to 10 sessions. Clients report that they feel like they've done some good work, right? Again, obviously, that's very subjective. Some people may be in therapy for years, other people may do sort of short term solution focused work. But just to give an idea of like, if you're going to go every 2 weeks for about 10 or so sessions, you're looking at like 20 weeks, right? Maybe like 4 to 6 months, like allowing for holidays and breaks and things like that. So you're kind of looking at like, do I have like 6 months where I can consistently attend appointments? And as well as the appointments, yes, of course, I'm not like a typical therapy hour is 50 minutes. I'm not gonna like wait until minute 49 and be like, okay, we're done. If you're like very, very overwhelmed and crying or, processing something, of course, we're gonna make sure like, okay, we've got 15 minutes left. Let's start to wrap this up and make sure that we calm you down and bring your nervous system back into the window so that when you leave my office, you can go back to your life. However, it is normal and common to continue processing information in between sessions. And there is an element of that the work continues outside of therapy. Obviously, in therapy, we only have that 50 minutes together every 2 weeks. And so if you do just leave my office and don't think about anything that we've talked about for 2 weeks and then come back in, you may find that the work just may feel like it progresses more slowly, right? So in your own time, you may be reflecting on things, and then it may be helpful for you to either be having your own like time to yourself where you can maybe go for a walk in nature and be present to some of the feelings that are coming up. You may feel that you want to do things like cry or get angry and shout and like, punch a pillow or do these things that help you kind of move through the emotions, journaling, art, whatever. But again, you are going to need some kind of time, capacity, space to do those things, right? So if you feel like your life is incredibly busy, like every minute is accounted for and there's like no extra time, no, it's probably not going to be the best time for you to be doing this kind of work. But again, obviously balancing, everyone is different. Of course, we have to just function and live our lives. But where can you allow yourself that space and that time to focus on yourself? That becomes a whole other topic because of course, in our society, we don't value self-care. Again, self-care is a bit of a buzzword. When we talk about self-care, we mean, can I identify my own needs and then can I get those needs met? So focus on self rather than focus on other. A lot in our society, it's very common and normal for a lot of us to feel like we should focus on other, right? Messages that we received growing up, think about other people, don't think about yourself, don't be selfish. Especially I think for women and mothers, there's an idea of like, we're looking after everybody else around us, I'm the last person that gets attention, right? So these are common themes, but I'm sure you've heard the cheesy cliche that we can't pour from an empty cup. And as much as it's a cliche, it's very true, right? That, as much as people might say, well, I have to just be a mother, I have to just focus on these things I have to do, we would always say, well, actually, looking after yourself is the best way to look after others. But again, that in itself might be a piece of work around how do you give yourself permission to really have this time and focus on yourself. And if it's that you physically do have the time, but it's the permission giving part that's hard, again, that's maybe where the therapy starts, right?
If obviously could, because we're speaking in this episode about like specifically sexual trauma,
Mm-hmm.
we can't erase it. We can't erase our past. When someone comes in to see me, I always keep in mind, what is your goal? What do you want to get out of this? And because again, they're coming to me for different, physical reasons usually. I don't want to have pain when I have intercourse. I want to be able to enjoy. I want to have pleasure. I don't want to have pain, like what have you. That would be their goal. What would you say is the goal of therapy? Because again, you can't erase it, but what would be the goal? Like, how do you know when, how does someone, mm, I don't want to say like, when does someone stop seeing you, but like, would you say
Yeah.
people say, Lucy, thank you.
Mm-hmm.
Thank you for all you've done. And then they don't book back in. What would you
Mm-hmm.
say they come to? What conclusion do they come to?
Yeah, I mean, of course, it's very subjective for each
Mhm.
person. But I think there is just maybe a level. I always would say, like, look at your everyday life. Of course, and like none of us are like feeling happy all the time, right? That's again like toxic positivity and is not helpful. So it's not that you're not going to have days where you feel down or sad or that something reminds you of that event and you kind of have a crappy day because you're like, oh, like why did I watched a film and it reminded me and that's annoying. But it's sort of like for me it's the ability to manage these feelings, right? So it doesn't feel, when these things happen, they feel manageable, right? You feel like you can um, tolerate the feelings and you have ways to cope, and it doesn't feel like it kind of like consumes you or overwhelms you to the point where you're kind of like incapacitated or unable to function. That it's a sort of sense of like, I can manage this, like it's okay, like it's not great, it's not a nice memory, but it's just a memory, it's there, and I can manage it, I can cope, and I can still live my life and do all the things that I need to get done and feel like I'm a functioning human being, whatever that means to you, right?
I always get goosebumps when people have that moment where they are just like, I did that, I'm on the other end, or I understand myself better, or I love myself more, or what have you. I always feel like that's such a powerful feeling. Lucy, is there anything else that you feel like I haven't asked you that you think is important to convey in this episode?
I think like circling back to just like really saying that of course we're using this platform to talk about sexual violence and hopefully helping people to know that if they're experiencing any of these things, that that's normal and that there's support for them. But I also just really want to say as well that if you're listening and you're a survivor and you're like, I don't experience any of these problems, that is also fine.
Mhm.
So there's no right or wrong way to feel or be after experiencing violence. But I guess the other piece would kind of maybe be relational, right? So of course, we see people coming in individually that are survivors and kind of coping with whatever's going on for them individually, but then also people that are in a relationship with other that can be hard, just maybe because there's maybe a level of course shame, and then there may be a level for the partner who isn't a survivor, who just feels like, I don't know what I'm supposed to do, like I don't know how best to support my
Mhm.
partner, and that can be very challenging. And so I think if there's any partners of survivors listening, to know that, it's very normal and common to feel like it's a struggle. Of course, if it's really causing issues in your relationship, that's where we would encourage maybe couples therapy would be helpful. But if we're just thinking about like how best to support, I think it's always important to just recognize that there is a lot of power in listening, that we don't have to have a solution. Kind of what we're talking about is like, we're not going to forget this thing has happened, it was awful, but it is what it is. So kind of like listening and recognizing we don't always need to provide solution. Of course, as I'm sure loving partners would, I believe you. This happened, it's awful. And then, what do you need? Like sometimes that there can be so much power in that question of like, what do you need from me? And that might be just, it may just be asking that question is what the person needs. But I know that there's other people who maybe just even it might be like if you are watching a film and there or a movie and there's a violent scene or a sexually violent scene, just even checking in with partner, like, are you okay, like, do we want to
Mhm.
watch this, do we want to like change it, just acknowledging like this exists, right? Because I
Mhm.
think there can be a sort of a desire to, I don't want to say anything in case it upsets the person, but sometimes that can lead us to feel like, oh, we can't talk about it, or it's not okay to talk about it. So I think, again, going back to checking in, what do you need, like, are you okay, this exists, is usually the most helpful thing that partners can do.
And something I always think about, there's always barriers to access someone like yourself or myself. And I think one of those big ones is, well, we're trying to help with just understanding in this episode, like helping to maybe just shed light, normalize, open the conversation. That's one barrier which I think we can address here today. But also another one is the financial barrier. So I think we all do what we can to be able to offset that in some ways. One of the reasons I do this podcast is to be able to share information that people don't have to pay for.
Mm-hmm.
When I put together the show notes, Lucy, would you share any resources or any links or anything that people can access? Um, if they have a hard time accessing appointments or something, like, are there any resources or community
Yeah.
initiatives or anything like that? I'll ask you to share those in the show notes. And
Mm-hmm.
would you also just let everybody know where to find you?
Absolutely. So the best way to find me is on my website, which is www.bcsexualwellness.com. So that's my website. You can email me through the website. You can also book directly online. My office is located in the Landmark 6 building, but I do offer both in-person and online appointments, depending on your preference.
Awesome. I will share all that, like the website and everything in the show notes as well.
Mm-hmm, mm-hmm.
Well, I appreciate your time. I thoroughly enjoyed that, and I will be sharing this episode a lot because this is usually what happens with obviously I'll share it in kind of different platforms, but whenever somebody comes in that makes me think of this episode, I often send it home as their homework. And again, my goal is always to say, like, I did an episode for a reason. You're not the only one.
Yes.
Helping to understand and normalize and help you realize you are not alone and there's nothing wrong with you, right?
Absolutely. Yes, absolutely.
So thanks for your time.
Yeah, thanks for your time.